Dr. Molina, how are you?
Fine, thank you.
Oh, thank you, and congratulations on your award. Well deserved. Before we delve into your healthcare career, I want to take a moment to acknowledge this beautiful room, and I hope everyone looks at the centerpiece. It's very, very creative. It was originally a reading room, Dr. Molina, for medical students from across the city, and it's the perfect space, of course, for our conversation this evening. Tell us how your passion for books and medical history came to be.
So I've always liked books, and when I started medical school, my father gave me a book called Classic Descriptions of Disease by Ralph Major. Ralph Major had traveled in Europe before starting medical school at Johns Hopkins in 1906, and he realized that many of his classmates couldn't read the classic descriptions of disease because they weren't in English. So he translated these classic descriptions and wrote small biographies of the physicians that were responsible. And then I read Cushing's The Life of Sir William Oser when I was a first-year medical student, and those things were what really got me interested in the history of medicine.
Yeah, and so the library recently held a day-long symposium for history of medicine professionals with a focus on the future of medical libraries in the digital age. What do you make of what's happening in the digital age?
Well, it's a confusing time.
Yeah.
People assume that everything's been digitized. The truth is, only a small fraction of all the books and journals have been digitized, and many of the older important things have not been digitized. So we need to have historical collections like the Rare Book Room at the New York Academy of Medicine to preserve our history of medicine, and without them it will be lost. And there are very, very few left. The New York Academy of Medicine has one of the best collections of historical works in North America.
Yes, yes.
So it's a critical cultural repository. These are cultural artifacts.
Yes, yes, and they're priceless. What do you think needs to be done? More fundraising so we can get these precious archives digitized?
Well, yes and no. I mean, part of it is digitization is nice, but it's also important to maintain the physical objects. Wow. Imagine if you had an art museum and we took photos of all the Picassos and the Rembrandts, and someone said, well, we can shred these now because they've been digitized. You would never do that.
Right.
So we need to preserve these physical books. We don't know what's going to happen to digital copies. But we do know that some of these books are 400 and 500 and 600 years old, and they have stood the test of time. So it's really important to protect the physical objects.
Yeah, and with that said, what do you make of AI?
I don't know. I mean, it's an interesting thing. It's in its infancy, and I think that AI is going to actually be very helpful for physicians because it'll help with diagnosis, and it'll help with things like differential diagnosis. Have you thought about this? Did you consider that test? But it's never going to replace the doctor.
Yeah, well said, well said. But they're going to try. You know they're going to try.
Well, some tech entrepreneur will try, but it will never replace the doctor.
It will never replace. Here. Let's talk more about healthcare. Like Dr. Hamburg, you're also a second-generation health leader. Tell us about your legacy.
So my father grew up during the Depression, and he had an affinity for helping people that were poor because he knew what it was like to grow up without much.
Where?
He grew up in Yuma, Arizona.
Okay.
And he ended up practicing in Long Beach, California, and he started 3 clinics for Medicaid patients. We had one in the Harbor area, one on the east side, and one on the west side, and each one served a different patient population. So the clinic on the east side was almost all Cambodian immigrants. This was after the war in Vietnam, and a lot of people had relocated to Long Beach. They didn't speak English. There was a lot of cultural dislocation, as you can imagine. And then we had the Harbor area was almost all Spanish-speaking patients, and many of them were uninsured. And so my father had 2, I think, basic principles that he believed in. And the first was to treat your patients like a family member. So ask yourself, is this how you would want your mother treated, or your father, or your children? That was one of the basic principles. And the other one is what we now call value-based care. And basically his idea was to put the finances in the hands of the doctors and let them make the decisions rather than having, accountants and lawyers decide what kind of care you should get. Place the physicians in charge. And I think that's still an important point.
Yeah, and how do you prioritize health equity in your health system?
It's a funny thing because when we started all of this, health equity didn't exist. Nobody ever come up with these words, but
it was still a thing.
It was, but we didn't really know it back then.
Right.
So
it didn't have a brand.
No, it didn't. It didn't. I'll give you an example. In the clinics in the east side of town, where all the patients were Cambodian, we had no patient education materials. Wow. So my father had to invent these things and have them all translated into Cambodian. So we had literature in English, Spanish, Cambodian, and Hmong. And we didn't do it because we were trying to be pioneers or do something different. It was just like, this is what our patients needed. Right. And so it was to meet the needs of our patients. And I think that is the root of this whole health equity movement. Right. And going back to what my father said, if this were your mother, if this were your father, is this how you'd want them to be treated? Right. And if you follow that principle, then I think we'll make big strides in health equity.
Yeah, that's very impressive what you just said. What do you make of all the barriers to care that still exist right now?
I had a doctor who was in charge of quality assurance for us. His name was Kevin Park. And I went in one day and said, Kevin, what can we do, to improve our quality scores? And he said, well, it's very simple. I said, really? Because we're struggling with this. And he said, yeah. He said, people want to get good health care. The problem is we place barriers that prevent them from doing that. And so the best way to improve the quality of health care is to remove barriers, especially barriers to access. But our system is very complex. The profit motivation, especially in for-profit health systems, gets in the way. Mm-hmm. And we've created unnecessary barriers in terms of things like prior authorizations. Right. And again, it's getting back to trusting the physicians, giving them financial responsibility and holding them accountable, but letting them make the decisions with the patient as to what is best for the individual patient.
Yeah, and do you interview the individual patients to get a sense of their needs?
Well, that's another interesting thing. Yeah. I was one of the founders of a group called the United States of Care, and you talked about maternal mortality. So about a year and a half ago, we embarked on a program on maternal mortality because it's shameful, the care that pregnant women and postpartum women get in this country, and that the maternal mortality rates are so high. But what most policy people do is they start at the top, and they get together with physicians and policy leaders and economists to try to tackle the problem. We flip that on its head. Mm-hmm. So at the United States of Care, what we do is we go out and we talk to the patients. We talk to the people and we say, what is it you want? What is it you need from the healthcare system? And what are the barriers you're experiencing that we have put in your way mm-hmm. that are keeping you from getting what you need? Mm-hmm. And I think that the sort of secret sauce of the United States of Care mm-hmm. is that we bring the patient's perspective into the healthcare policy debate.
Very interesting. And you called it shameful, and it is shameful. As someone who's very experienced in this field, what do we need to do to move the needle? I know you talked about interviewing the patient and everything, but this seems to be an intractable problem.
Well, the science of medicine is good as far as it goes. Mm-hmm. But one of the things that we need to do, for example, is make sure that women have continuous health care coverage over the first year after their pregnancy. Because a lot of the problems, something like half of all the maternal deaths occur 6 months or more after the baby's born. So, this episode of care doesn't end with discharge. It doesn't end with that 6-week postpartum visit. It needs to go on for a year, and we need to be conscious of all the problems that women encounter after the baby's born. Yeah,
let's talk about community-centric decision-making. That's something that's very important to you.
Well, yeah, what do you want to know?
Well, how does it play into reducing barriers to care?
Again, it's you go out into the communities and you ask people, what is it that we're doing as a healthcare system that's getting in your way? Mm-hmm. because we often don't know, or we become so close to the situation that we don't see it. And then you go talk to people and they say these things to you and you look at them and you go like, well, God, who would design a stupid thing like that? Oh yeah, we did. So you need that perspective of the people on the other end. It's the same thing when you design any product. If you were going to build a car or a cell phone or a television, you would ask the customer, what is it you want and need? Not, you wouldn't say, this is what you get. And real innovative people are going to go out there and find out what people want, what they need, and then deliver that.
Yeah, your leadership clearly helped bridge the gap to healthcare access for all. Given your experiences, share with us your perspective on the next milestone to achieving true health equity.
Yeah, it's several things. It goes back to there are two basic problems, I think, with healthcare in our country today. First, it costs too much.
Right.
It's so expensive that it becomes an impediment for people getting care. And until we attack the fundamental underlying problem of the cost of healthcare in this country, we're never really going to make any progress. The second thing is access to care. We don't have enough doctors. I mean, this is becoming a critical problem, finding people who will take care of the patients.
Why do you think we don't have enough doctors? What's happening there? Why aren't more people going to medical school? Is it too expensive? Do they feel priced out?
Certainly cost is an issue, although I think it's becoming less of a barrier as more schools are finding ways to help students.
Right.
But there are a lot of people who want to go to medical school. And the growth of the medical schools has not kept pace with the growth of the population, especially for underserved minorities. Right. If you look at Black and Latino students, while the number of graduates has gone up over the last 30 years, the percentage of Black and Latino physicians in the workforce has remained flat. Right. At the same time, if you look at the Latino population in this country, it's somewhere around 25 to 30%. Right. And so there's this mismatch between the patients and the people that are caring for them. Yeah. So you want to improve healthcare, lower the cost, and improve access to care.
That's interesting. And what do you think is on the horizon for equity that needs to be part of any vision for the future of health and health equity? We touched on that a little bit.
Yeah, I mean, I think, again, you need to individualize the care for the patient. Right. And as the country becomes more pluralistic, where we have, I mean, when I was growing up in Long Beach, for example, I think 95% of the population was white. It's now about, I think, 48% Latino. So as the patient demographics change, our healthcare system has to adapt to that, and it hasn't. We're lagging way behind.
And I want to go off script a little bit. What are some of the lessons learned from the pandemic from your point of view?
Whew. The pandemic was really different. I was thinking about the difference between COVID and HIV.
Right.
With HIV, it was a smaller number of patients that got sick over a longer period of time, and it was a minority group, so that people weren't quite so concerned. It was somebody else's problem. But when I was a young doctor and we had patients who had AIDS, their life expectancy was about 6 months. So it was like having a rare cancer. There was really nothing we could do. COVID, we kind of knew what to do, and we had the science to address this very quickly. The problem is we kept tripping over ourselves. We didn't have the infrastructure. We've talked a little bit tonight about public health. The public health system in this country has been starved for years. We thought we had everything nailed, and so we kind of ignored public health, and then we have this public health crisis, and we were not prepared. We didn't have the staff. Right. I mean, I know that in Southern California, for example, we just didn't have the systems in place to rapidly respond to this problem. And that would be okay except for one thing. It's going to happen again and again and again because pathogens evolve. And there will be new viruses that, come from places that we weren't thinking of or that have changed. For example, dengue fever. This is a tropical disease. Nobody gets this, right? Or West Nile virus. Well, in Southern California, we now have these diseases that years ago nobody thought about. Mosquito-borne illnesses are going to be a big problem with climate change and with the fact that we don't have good mosquito abatement programs. So all those public health programs that we had in the early 1900s that we thought we'd solved all the problems, they're coming back.
Yeah. Are we ready to deal with it?
No.
The communication gap between the federal government and how it trickled down to doctors was abysmal. The federal government was saying one thing, the local health agencies were saying another, and then the doctors were left to figure it all out.
I'm not sure that's entirely true.
Oh, tell me what you think.
I think that a big problem had to do with disinformation,
Right.
The anti-vaccine
Where
movement.
did disinformation come from then?
There are a lot of people, for whatever reason, there are a lot of people who no longer believe in science. When I was growing up, people in the 50s, 60s, 70s, science was very important, and that seems to have kind of gone out of fashion. Yeah. And so we don't trust scientists anymore. We don't believe in empirical data, and we love conspiracy theories. Right. So, we don't vaccinate our kids. We don't believe what people like Anthony Fauci tell us about the disease, and it's become so political that anytime someone stumbles or tells you something that we believe today is true, but we find out later on is not, it's not a conspiracy. It's a mistake, or we've learned new things, and we have to adapt. But there's a lot of things that are being promoted that are just bad public health, bad medicine.
Well, you make good television, I got to tell you.
Thank you.
Thank you. It was nice meeting you.
Nice to meet you.
Nice to meet you.